You, sir. Now it's time for second presentation. The topic is ICL when LASIK is not for you. The presenter is Dr. Ashraful Huq.
Assalamu alaikum. Dear respected delegates and the audience at the 7th annual conference of Bangladesh Eye Hospital Chattogram. First of all, I would like to give thanks to invite me and give me the opportunity to talk about ICL. So ICL, what is ICL? Implantable columnar lens. And the ICL, we call it the Phaco or implantable contact lens, implantable columnar lens. Now we are getting it in Bangladesh by the Vision implantable columnar lens by the Star Surgical. And it is basically placed in the posterior chamber Phaco and placed behind the iris with the haptic resting on the ciliary sulcus. So who are the candidates for ICL? When we're correcting the refractive surgery, we talk lots about the LASIK, but now ICL is now in Bangladesh, and those who are not suitable for the laser-based corneal surgery and who have the very high refractive error. As we know that with high refractive error, we cannot correct it by the LASIK or PRK. So we can go for ICL for those patients. Also, the topography is not suitable. That patient, we can go for ICL. And for the evaluation, that is the thing that we have as the LASIK age, 21 to 45 years age with stable refraction and no other ocular pathology, that are the good candidate for selecting ICL. So this lens has the design of the plate haptic, and we can see that we have 3 holes in the body, and the center hole is designed to eliminate the need for the perioperative iridectomy or preoperative iridotomy to allow the natural aqueous flow. So the question could become that when we place the lens behind the iris, the pressure could be raised, but this hole allows the aqueous flow, which normalize the pressure. And usually we do up to 18 diopter and correct astigmatism 6 diopter with the ICL. So preoperative assessment for these, the complete ophthalmological assessment is needed. We need to do the uncorrected visual acuity, best corrected visual acuity, refraction. We need to do both manifest and cycloplegic refraction, complete slit lamp examination, intraocular pressure measurement. Angle evaluation is a very important part. And I would like to emphasize that if any patient has the pigment dispersion syndrome, we would like to think that this patient should go for ICL or not, because the pigment dispersion syndrome, this patient has the chance to increase intraocular pressure after the ICL implantation, and obviously the fundus examination is needed. And investigation is like the pre-LASIK investigation, and the corneal topography, biometry, endothelial cell count are the most important, along with what we see that anterior chamber depth, that is the internal anterior chamber depth, that may mean that from the endothelium to the, that is more than 3 millimeter. But we can consider 2.9 millimeter, but the 3 millimeter is the best. And the white to white measurement, we need to go for with the digital calipers, IOL master, and the Pentacam UBM. So better to go for the digital calipers, optical white to white measurement, and the Pentacam evaluation. And after collecting all the data, we have a data sheet provided by the Star Surgical. So we input that, and after that, the lens power is calculated, and the lens is provided by them. But one thing we need to ensure that there is a two lens for two eyes, right eyes and left eyes. So these are the two separate lens. The right eye lens I cannot implant in the left eye lens I cannot implant in the right eye. Now I'm going to the surgical process. And this is basically the cartridge where the ICL is placed, and this is the SF45 model sterile disposable cartridge we use. And here we first inject the gel, and we get the lens in a vial, and also along with it we get a foam tip plunger. With that we handle the lens. This is the implantable colomal lens. And we insert in the cartridge with this foam tip plunger. And we have a special lens holding forceps, that is, and we need to place it in the cartridge. And when we pull the lens, we know that this lens is very soft, so we need to manipulate it very softly. And we hold the lens and bring it towards the tip of the cartridge. And this is the plunger, and we also use the foam tip plunger with the shooter for this ICL implantation. And after the lens is ready, we go for the incision. As this was the toric ICL, I need to little bit rotate it, so I did do the marker, and we go for 2 side port and 1 main port, and the main port is the 2.8 millimeter main port. So and after that we inject the implantable contact lens like we inject the intraocular lens. One thing is that it's better to go for the in AC implantation, and it should be go slowly because we are seeing the haptic is opening up, and we need to see the whole of the leading haptic is on the right position, because otherwise it could go otherwise rotated and it will not be in position. And after that, we have a manipulator, ICL manipulator, and with that, we place it behind the iris. First, we go for the leading haptics, and then we go for the tail haptics. And also after the fore haptic is placed behind the iris, we go for the rotation, where we should actually place the toric side. And after the lens rotation and the position is done, we go with the bimanual irrigation and aspiration to remove the injected viscoelastics. And this is basically the ICL surgery, implantable colomal lens implantation surgeries. So after the surgery, the post-operative assessment and the post-operative management, we need to see the status of the cornea, the vault of the vault, and the intraocular pressure, and the toric ICL position. The main important is the vault. It is the distance between the posterior surface apex of the ICL and the anterior apex of the crystalline lens. We can see it by the anterior segment OCT. So over the time, what is the advantage over the clear lens exchange? We can go for clear lens exchange or we can go for ICL, but the advantage over the clear lens exchange is the patient's natural accommodation is retained, and there is a less vitreous chance of alteration in case of ICL, and ICL is always reversible, and it is always suitable for the high refractive errors. So last of all, we want to say that now the clear lens exchange, LASIK, SMILE, PRK, and ICL, all kinds of refractive surgery are available in Bangladesh. The surgeons of Bangladesh are doing it. So when patient comes that I want to do LASIK, I want to do ICL, it's actually difficult to say the best candidate which refractive surgery you need, before doing the preoperative evaluation. And after preoperative evaluation, the surgeon can fix that what is the best refractive surgery you should go for. But the good part is that we are doing all in the Bangladesh and Bangladesh Eye Hospital. Thank you.
Thank you, Dr. Ashraful Huq, for your nice presentation. Now I'm Dr. Mayank to give Dr. Mayank Nanavati.
Yeah, thank you so much for a very nice presentation, Dr. Huq. I will just have a few comments on your presentation. Excellent technique and excellent surgery. Excuse me. I have learned through my experience that using your foam tip injector is sufficient rather than the forceps to pull the lens in the cartridge. That saves on the cost as well, because the forceps are quite expensive. The second thing is your tip, which you just showed in the video, is excellent. You have to tuck in the distal haptics first under the iris, followed by the subincisional haptics. Otherwise, the pupil starts shrinking because you get a lot of irritation in the subincisional iris and the pupil starts collapsing, and that's a nightmare. And the third tip is you can use ICL for other conditions such as keratoconus and any other conditions which can affect astigmatism, for example, post-corneal transplant patients, which we use quite frequently. Listening to the first presentation by Dr. Tanuja, I think most of the cases she presented in the first presentation were candidates for ICL, in my opinion, because they were young patients, high myopes, and I would refrain from doing LASIK in those patients. So I think there's the example which she showed at the end of the presentations were classic examples where I would use ICLs in their 20s and 30s. Also, a comment on the first presentation. I moved on from LASIK in such high prescription patients. I use Streamlight, which is a transepithelial PRK, which is much more effective in terms of refractive correction. But if you use mitomycin in all these cases, your refractive outcomes are at par with LASIK in these patients. And you also get less dry eyes in my personal experience. So thank you.
Thank you.